Thank you for that presentation. For those of you that don't know me, my name is Meghan O'Connell. I'm a citizen of Cherokee Nation and the Chief Public Health Officer for the Great Plains Tribal Leaders Health Board. We serve the 17 tribes and one tribal community in North Dakota, South Dakota, Nebraska, and Iowa. I have also brought with me my colleague and friend, Chris Alibrandi O'Connor from the Network for Public Health Law, who is an expert in public health and tribal public health, and a lawyer. So if we have legal questions, she's here to answer them. For those of you who've heard me talk on these issues before, even in this group, I apologize if some of it's repetitive. For those of you that haven't, hopefully it will be useful. So let me get started here. And as we go, if there are questions, please let me know, but I'm also happy to start. Oh, I can't share my screen. That's okay. I'll just get started. I promised that I did this before our presentation from CMS, but my very first slide states that what we do as TECs and what we're talking about is not research. We do public health practice, which is different. And I understand that there's not a process for that right now at CMS, but I think that's what we're here to discuss. And that's really important for what I'm going to talk about throughout the presentation, because having that distinction between public health practice and research and the specific legal framework that tribes and TECs, as well as states and federal agencies, fall under with regard to public health practice and the ability to use protected health information to do public health activities is really the heart of what we're talking about. So that is why it's my first slide and why
and
we're here to do that. I can get it.
Okay.
Thank you.
Mm-hmm.
Meghan, at any point, if you want me to jump in with any legal explanation of that, I'm happy to.
Okay, I can, we can go to the end unless you think it needs clarification, Chris, but all right. So just briefly, again, apologize for those of you who don't know, but especially our guests. We're talking specifically today about tribal epidemiology centers. A lot of what I talk about is similar, although not identical for tribes, but I'm going to focus on TECs and these are the 12 TECs. There's one for every IHS region and one for the urban Indians throughout the country. So it kind of covers the whole country. So again, focusing on TECs and the work that they do and the laws governing their access to data, some of which overlaps with tribes, but they are not the same. And I also want to say by statute and practice, that any of the work that the TECs do is supported by the tribes. It's actually at the request of and in consultation with in the statute. And so although I am not a tribal employee and I don't work directly for a tribe, anything that I'm requesting or doing, like even this presentation, is it has been approved in one way or another or asked for by our member tribes, which is every tribe in our area. So there are 7 core functions as mandated by Congress. Congress established TECs in the early 90s, and all of these functions are essentially public health activities. And that is what we do in our day-to-day work. Sorry, I was just checking the chat in case there was a question. So why does this matter? Tribes and TECs are both working to improve the health of Alaska Natives. I think everyone on this call is from different perspectives, but we have this united goal to improve the health of Native people. But as public health professionals, especially as epidemiologists, we need data or information to make sure we can do this, which we, again, I think many of on this call are aware of this, but for any response to know what's happening in the community, you got to have data. But it often doesn't work that way. So as we've even heard today, there are often processes that did not take into account that were established years ago that didn't take into account TECs when they're trying to seek this data. So the data is often collected not by tribes or tribal epidemiology centers themselves, but within the public health or medical system. And there are no pathways for tribes and TECs to receive that information. So then we have to ask them or you, in the case of CMS or a state or CDC or IHS, to try to get it to us, because when that system was created, tribes and TECs were not built into it. And so that's why we're constantly asking these different groups to try to give us data so that we have access to that information so that we can monitor for public health threats and make good public health programs. So this is a problem. It can be very challenging to get data, with respect to CMS. It took, we are starting this process. I will just want to note, I applaud the efforts of NIHB on getting the agreement, but to be very clear, NIHB is not a public health authority, and so that puts them in a very different legal category than we are, and their ability to receive PII or PHI, protected health information. There are challenges in receiving this across the country. In, I think, a year ago now, March 2022, the GAO put out a report about this very specific problem, specifically as it relates to TECs and HHS. And so I encourage you to read it. I think we have the link for you, but the punchline is TECs are unable to receive information, even though it is mandated by Congress that we are to be able to receive any information essentially within HHS, which includes the data in CMS. That is the law. So it's not just that TECs are public health authorities and can receive PHI because of HIPAA, like other public health authorities, state health departments, for example, but there's also a mandate for all the agencies within HHS that we are to receive this data when we ask for it. And that mandate has never been fulfilled. So there were several recommendations. There were 5. I'll talk about the one that was to HHS specifically, but they pointed out that there needs to be clarity on this, a policy that provides all of the agencies with how to do this. And as you noted, that the data is supposed to be made available to TECs by federal law. And for any attorneys on here, that is it's 25 USC 1621M. It's the 2010 amendments to this Indian Healthcare Improvement Act that was passed as part of the ACA. So that has now been law for 13 years and never completely been fulfilled. So to kind of maybe put all these together, TECs are public health authorities. Unless we are doing research activities, everything else we do is public health. So if we're doing public health activities, that is under our public health authority, and we fall out of HIPAA. We are able to receive PHI without patient consent, just like other public health authorities. It is a specific exemption for the receipt of PHI in terms of having patient consent. And we fall under that just like other public health departments or federal agencies like the CDC, which makes us different than researchers. Additionally, federal law mandates TECs access to essentially all HHS data. This is, again, it's in the statute. Go read it. I have a link to the actual statute that we'll share with you. And the GAO report pointed this out, that TECs are supposed to be able to receive data held by HHS when it's needed and when we ask for it. Now, to no fault of any individual's own, the systems were not set up to support that. And what we're trying to do is work within the system to make sure that the law is being followed and that TECs and tribes can get the information they need to successfully protect the health of their people. So from my perspective, the reason I care so much about this is that this is really about health equity. We can't ensure equitable outcomes until we have equitable access to the data and ease of access to the data that we need. States get access to CMS data because they administer Medicaid programs, for example. Tribes are not allowed to administer Medicaid programs, even though they are sovereign nations. And so we need to find another way to work together to get access to this. And I think this process that we're discussing is a great start, but some of these differences and how TECs are seen under the law and the unique relationship that TECs and particularly tribes have with the federal government. They're not just organizations or universities or private entities, they're nations. The tribes are for sure. And I work for a health board, which is a tribal organization, that we all need to work together to figure out how we can get this information to TECs and tribes and into those communities to try to improve and protect the health of Native people across the country. I see a lot of things in the chat, so we'll see what those say.
I think that was mostly me putting in the links, Megan.
Okay.
And also apologies, the last one I accidentally forgot to copy first. So anyway, now they're all in.
All right, so happy to take questions, or Chris, if you have any comments after that, go ahead, maybe we'll give you the floor.
Sure, just for a couple minutes. So my understanding of the discussion today was, at least this part of it, was following up on the GAO report's recommendations that HHS accepted to address the issues that TECs have been having systemically with getting access to data from HHS. So having just reviewed the GAO report and the 5 recommendations that were made, that to the GAO, the Government Accountability Office, right? I assume everyone on the call is familiar that the recommendations they made documented the challenges that TECs had getting data, and the specific recommendations were for, if I remember, I always remember 4 of them and I forget the 5th, but basically for CMS or HHS to develop a procedure, a process and a procedure for TECs to make requests for data, and then also a process and a procedure internally for handling those requests. And I think it was 2 more were the same mirrored recommendations for IHS, and I never forget the 5th one, my apologies. But I was in listening to the earlier presentation, I see, I'm a little surprised, I'm seeing a little disjointness because HIPAA recognizes TECs as public health authorities. And as Megan was saying, public health authorities have certain powers, to access to data, and HIPAA treats very differently public health authority access to data than it does the showings you've got to make to access for research purposes. Matter of fact, the Network for Public Health Law, we're all about public health, and my focus in particular is not about research, but I know that there are different legal standards under HIPAA for accessing identifiable information for research purposes as opposed to for public health purposes. And so I'm not sure if this, I guess what I'm seeing is, I'm not sure if this ResDAC avenue is necessarily responsive to the GAO request, because it at least from a legal perspective, how HIPAA applies to research requests is very different than how it applies to public health authorities. So anyway, that's my dropping a dime on the legal part of it. But certainly, as Megan was clear in presenting the law that you were talking about, how TECs have, under federal law, have authority to access. Essentially, I mean, I think if the law actually reads, the secretary shall grant to each epidemiology center access to the use of the data sets, delivery systems, and other protected health information in the possession of the secretary. So it's very broad. Clearly, it was congressional intent. So I think that may be enough, hopefully, for the legal part that I want to just throw in there. Megan, back to you.
Thanks